today. I think Martin unfortunately got to know me about a year and a half ago. I think it's more fortunate for me. There's a lot of wonderful work ongoing, and as Minister Swan said, our way of working is collaboration. I'm going to use Martin's new word, coepetition, and another word today is super colliders. We've met a lot of interesting opportunities and people today as well, so I think those are very important. So we've been trying to work on digital linked to polypharmacy and the long-term condition areas, as mentioned by Mike O'Connor this morning. I think there's a lot of work can be done there, and digital enablement with lots of very interesting systems, not least the epilepsy system we heard just before lunch. I think that's very important, and it connects with work we're doing led at the University of Maynooth. Again, Professor McGuigan, we're involved in a large European project looking at supporting older citizens in their own home with digital enablement. We're leading on the medicines piece, looking at multiple diseases there, cardiac, diabetes, respiratory, and see how we can optimise that at the self-management level. So I think we're very keen. Hopefully Martin and I got the MOU signed, so we've got a ministerial approval, and we'll be able to maybe link in lots of potential projects so we can then work on lots. So we'd like to try and see how we can bring into our system to meet our objectives, and also hopefully translate that and gives a good all-island facility to do research to be attractive, hopefully for folks wanting to produce new technologies, even shiny new objects. Martin saying whatever we wish to do, that gives us great capability and great funding opportunities. And Martin and I already put in joint funding bids, and also with academic colleagues as well. Professor McDonough's in the thing from RCSI in the audience, so that's what we hope to see. That gives us great energy right across the island. So it was great to actually get along here, learn those two new words, and the third was Tullamore Dew. I think Martin and Zilla when you said they're all. So thank you very much indeed.
Just to mention, the Irish Independent have published a supplement today focused around the conference. We had 400 copies shipped to the hotel, so it'll be hopefully available. We have the tracking number. We're just trying to figure out where they are, so they will be available for you to take home. Our next announcement, many of you will know Brian O'Connor. He is the chair of ECHALLIANCE, and he also is the CEO of Connected Health, so we're delighted to be able to announce a collaboration. So Brian, please come to the stage. Thank you.
Thank you very much. I'm going to take a risk and ask you all to do one thing, which is to agree with me that this is a breath of fresh air, this conference, compared to so many others. Martin, Jim and the team deserve huge credit for having the courage to do what they're doing. And I'm delighted that all of you are cooperating. Very briefly, because it will take no more than 2 minutes, I'm fortunate in being the chairman and the founder of the European Connected Health Alliance. It shows you when you think of a name for a new venture, that sometimes you don't think big enough. I thought I was thinking big when I thought we'll call it the European one. This was 10 years ago. And as I was the only one in it, no one argued. So now we did that. We came to Dublin about 8 years ago, I think it was 7 or 8 years ago, and started off the ecosystem here in Ireland. When I saw Martin's presentation this morning, I saw immediately the circle that we use to incorporate all parts of the community and the sector. And I'm delighted to see the way this has grown so fast and so directly, partly because of COVID, but in my opinion, partly because of the leadership of this man. What we're doing today is simply agreeing that this ecosystem here will now become part of our geographic ecosystems across Europe and the globe. We have 71 of those at the moment. So similar matrix and mix of people as are here today are replicated across all of those. We also have the thematic innovation ecosystems. I can't say that very well, so I call them ties. It's much easier. And remind me of the days I used to wear a tie, actually. And what they do is they take a particular topic where it's integrated care, mental health, that sort of data ecosystems, and we bring people across all of those countries. I'm delighted to have such a vibrant Irish ecosystem as part of that network. You can teach us, and many people around the world, a lot. We also, we here can learn a lot from other people, because this collaboration and connectivity, and above all personal connectivity, will make a huge difference and is making for the good of people. The last thing I'll say is on connected health, I'm not very good at thinking of new names, as you probably gather. So one of the other things we started about 5-6 years ago on a personal basis, an investment I made in a company called Connected Health, based in Belfast at that time, domiciliary care, as they used to call it. I hope they'd stop calling it that. And we developed then from about 30 people to about 1,200 people now, carers. It's in Belfast, Ireland, I would just say Dublin, but across Ireland, and now in England as well. We are a technology-enabled care company, so anyone that's got anything which can assist us in caring for people in their own homes, that is where the care has to be in the future, and only the exceptions need to go to the acute care sector, then talk to Ryan Williams, who's at the back, or myself, because we really do want to transform and create home care 2.0. And 10 days from now, we're announcing opening a new office here in Dublin, our headquarters here, and we will be announcing recruitment of another 500 carers. We've got to get to about 2,500 carers by the end of this year, this calendar year. We're at 1,200 at the moment. I've just set a new target for Ryan sitting at the back. I thought it was only less than that. But just to say, the main theme today is collaboration, cooperation. We're thrilled to be involved and delighted to work with Martin and the team. Looking forward to working with you as well. Thank you for listening.
Fine, there's another person who needs to get a flight to save his marriage as well. You're also going on holidays, so. Our last, Ken Finnigan here. We signed an MOU last December actually with the CEO of EIT Health. We also signed an MOU with the Province of Trinity, and we've actually had a long collaboration with Tangent. Ken Finnigan is the CEO of Tangent, and there's a really exciting announcement that we're going to make, and there's a 10x, but we'll let Ken explain it. Okay.
Hello everybody. So Ken Finnigan, CEO of Tangent, Trinity Workspace. I'm also actually on the Public Service Advisory Board and chaired the recent Public Service Innovation Fund where we gave away $750,000. And the amount of applications coming in from the health service was incredible. Like you can see that these type of events are inspiring people. So keep up the good work. So yeah, we have in Tangent we run multiple different education, incubation and acceleration programs. Lots of different thematic areas, but we're very much focused on health at the moment. We've recently launched a healthcare innovation postgraduate program, but we also partner with the European Institute of Innovation and Technology. So we've been running accelerators in the health space for the past few years. When myself and Martin spoke recently, it just makes sense for us to partner around our accelerators. So we're running 2 accelerators this year, and we're going to align ourselves with the shift left, stay left, X10 mandate, I guess, or approach with our accelerators. So really excited about that. We will be recruiting 10 startups, or 20 startups actually on the 2 accelerators. Because it's the EIT kick, the health kick, we'll be recruiting from across all of Europe. So it's not just in Ireland, so we're able to bring in kind of like the best startups from around Europe onto these programs. Parameters we'll set will be geared towards helping kind of like the HSE and achieving the goals that are set out here today. So really excited to be partnering on this, and yeah, look forward to helping change the scene. Yeah.
Brilliant.
Thank you.
Thanks. So the next here is we're going to accelerate, you know, the startups so that we can get them ready for you know, early adoption to living labs. I think what we've committed, we're going to take the top 2 winners and actually create a HSE living labs, which is tremendous. Clearly we have a problem here. We have fabulous speakers and we don't have a lot of time. So what we suggested is we're going to do the demos. We have some brilliant demos. And then we're going to ask each of our keynote speakers to come up and speak for 2 to 3 minutes. I'm hoping, Siobhan, you will help me with that, and just to get, you know, share their thoughts. And like, I know people, Ger, I mentioned her, what, you know, Irish Life have been doing with my life and where we might go with that, and Caroline Whelan. And we still have some amazing demos, you know. You won't want to miss Jimmy and John Sheehan coming together. It's absolutely amazing. We're going to be looking at a live brain scan, and this just happened in 2 weeks. So please stay with us. And there were many other things we could have shown. I see Ronan Colleen there, and the work that he and Mitchell of X-Wave have been doing really amazing in terms of inappropriate prescribing and saving capacity. But please bear with us. We definitely need to do 2 days next time. Richard from C2I said it's the first conference I've ever been at where nobody's pissed off that we're way over scheduled, so I hope that's true for some of you. So now we're going to move to James and Catherine McGuigan, who have been doing this remarkable project in Wexford. So Catherine is CEO of Age Friendly Ireland and has a famous brother, just to mention. And James is the CEO of Tunstall, and Jim McGuigan and I had a chance to be with James about 3 or 4 weeks ago in Bunclody, and what we saw was really amazing. So should we show the video first, or how do you want to?
Yeah.
Great, if we could show the Tunstall video, please, the Wexford video.
The Wexford Living Lab Pilot Telehealth Project is a collaborative remote monitoring initiative undertaken with older adults living with chronic diseases. And so we want to tell you about the project and how the evaluation findings have led to a demonstration phase, which will run across the 5 counties in the southeast this year. An ageing population is marked with an increased prevalence of chronic diseases, and such diseases are major causes of morbidity and mortality. In 2020, it was estimated that almost 1.3 million people in Ireland are living with a chronic disease. The opportunity for the pilot arose through the collaboration between the partners, Age Friendly Ireland, Wexford Older Persons Council, Wexford County Council, Tunstall Emergency Response, and the HSE, including the Acute Hospital, Older Person and Integrated Care Services. Older adults in County Wexford got the opportunity to remotely monitor their chronic condition, where the overall aim of the intervention was to support them to manage their own health condition in their own homes. As one participant said,
I'm registered with the Resident Department of Wexford. And then Niall in Wexford rang me one day and said, "We're doing this project, would you like to try it?" And I said, "What's it about?" So he went in and said, we start things every day for 3 months. And I said, "That's fine, it's only takes a few minutes to do it." And so that's really, and I thought, well, yes, I give it a go. And it was actually very good, because every day I was actually assessing my own blood pressure, my own everything, you know. So I do for 3 months. I was very healthy anyway, you know.
the technologies used in the study were the My Mobile patient app and Clinical Triage Manager. The My Mobile app enables self-management and monitoring, and patients are provided with the equipment and they are asked to undertake this monitoring daily. And the patient is also provided with a tablet, and this is preloaded with the My Mobile app and clinical interview health questions. And there, the patient logs in daily and is reminded as to what they need to do, for example, take their blood pressure. And the readings are then sent to the My Mobile app via Bluetooth. And once the patient has completed the readings, the information is viewable by the Tunstall operator. And the Tunstall operator can then follow up with the patient if a reading is missed or if there seems to be a problem with the equipment. And the patient's readings are also sent to the clinician, where on the Clinical Triage Manager system, a traffic light system is available, and the clinician can identify critical patient needs. So, 3 clinicians took part in the study and they recruited patients, 2 clinical nurse specialists and 1 consultant geriatrician. 32 patients with COPD, CHF or diabetes completed the 12 weeks of the intervention. In line with stay left, shift left, the pilot study identified positive impacts on quality of care, life, clinical experience and cost. After the intervention, 85% reported that the intervention had helped them with the management of the condition. As the carer of one participant said,
he liked to see his own progress in a way. His medication had been changing at the time, so his weight was going down as a result of less water retention, so it was a nice way to track his progress for him. It was also a bit of peace of mind.
there was really good engagement by the participants with the technology. Only 2.6% of daily readings were missed. With regards to quality of life, participants spoke of how the device gave them increased confidence and how they felt more connected to their doctors and that they had a sense of security.
It did a lot for his confidence. I know he was very wary at the time about going to appointments?
Participants found the technology very easy to use as it has a very simple interface. The cost of the intervention per individual patient for the 12 weeks, including the clinician time and equipment, was just over €2,150. And while there were difficulties in determining the impact on the health service utilisation, as this was a small-scale, time-limited study, the findings do suggest that the patients and clinicians see the benefit of the intervention for cost savings, both in terms of time and travel for patients, and also for clinicians in that they can monitor the patients without the patients needing to attend the hospital. So in summary, the solution tested was remote monitoring of patients with COPD, CHF and diabetes for 12 weeks via the My Mobile Patient app and Clinical Triage Management System. The evaluation identified the success of the pilot study from both the patient and the clinician perspectives, and recommendations from the pilot study will be incorporated into phase 2.
Great. Amazing comments, I think, of the patient in terms of taking their own blood pressure, and that's where we want to go and stay left, shift left. So, Catherine, you've kind of been a main driver behind this. You know, what are your aspirations, and maybe you could tell us about the next phase that's about to happen.
Okay, thanks, Martin. I suppose his career span, 30 years, particularly working with older people, I suppose a lot of challenges have been raised to us, particularly through the shared service in terms of, you know, access to healthcare. So what are the challenges that older people feel? And we listen to the citizens. So like transportation, you know, or a lack of thereof, missing consultations, missing consultants' appointments, and better empowerment and needs to feel empowered, you know, in terms of the management of their own chronic diseases. But as well as that, even, you know, repeated admissions to emergency departments are very, very disruptive on older people, plus deteriorations occur when exacerbations occur, and then also staying in hospitals for longer periods of time. And I suppose what we've heard in response to older people is how are we actually looking at the shift left, stay left? How are we moving the care back to the community, as is the I suppose, objective of Sláinte Care? So the opportunity arose through the integrated care programme to start a small trial in Wexford. And as you know, that's been scaled up now across CHO Area 5. And because we had some challenges, despite the pandemic and despite all those things of not, you know, the installations being delayed because of older people being in their own homes, it actually harnessed those opportunities because older people were very, very concerned about travelling into the acute setting. So they started to use the technology, and we had a 97% participation rate, but satisfaction with that. So older people were regularly taking their readings, engaging with it. And there is that thing when you're actually seeing your own results coming through and your own vitals coming through, and maybe seeing, you know, I suppose, improvements on a daily basis, that the older person becomes empowered, particularly if it's, you know, just post-early diagnosis of diabetes or CHF. So I suppose we really talk about person-centric approach when we're talking about care, and, you know, the dividends, you know, in terms of not only the quality of life outcomes for the patient and the cost effectiveness, but the dividends that it pays for all the family members and everything else when that person's health outcomes are improvement. So I think, Martin, the scope of the programme where we are now, scaling up to CHO Area 5, what we then want to see is how are services like this, managed services like this, going to be mainstream.
Brilliant. I think, you know, what's happened is, I was talking to Kate Colin last night at dinner. She is hugely supportive and sees the opportunity for CHO5 to be the lighthouse for the rest of the country. So she is a really strong champion, and Kate Colleen White is the Chief Officer for CHO5, and it's brilliant to have her behind this. And James, we're going to do a quick demo in a minute, but as I said, our visit, what you're doing in Bunclody, you know, I think in Fermoy, Leia have their call centre, but I think in a year or two people will think of Bunclody, and this is where a lot of patients across Ireland you know, will be supported from older people. Now there'll be a bit of competition from Carlo, but competition is good as well, and we'll hear about that directly after this. But tell us, James, you know, what are your thoughts on the 10X, and then we'll do a demo as well. I can't wait to do this.
Okay, Martin, thank you very much. I suppose throughout my career in the healthcare sector, it's probably 15 years at the coalface, things have evolved completely from a traditional button and box solution, which would have been telecare in its most raw form, to the wearable you have in the wrist today. I think the needs and demands of a person of 65 plus now today is completely different than what it was 20 years ago. And I suppose it's incumbent upon us as a technology provider to embrace that change and to find solutions. And that's what collaborations like today really give us the opportunity to tap into. So it's really welcome the opportunity to sit down with like-minded people.
What I saw in Bunclody when we visited was the combination of technology and empathy and care. Maybe talk about the profile of people that are working in your support centre and how they deal empathetically, if that's the right word, or empathetically with the older people you work with.
Yes, so I suppose we've 54,000 clients around the 26 counties, and so effectively we have a 24/7 and as a monitoring centre as opposed to a call centre environment, which I always feel is a fundamental difference. And the empathy Martin refers to is if I've had a significant medical event or I've had a bad fall, I don't want somebody to try and get me off the call. So typically a call to our monitoring centre may take 20 minutes, half an hour. We'll stay on the line with you until help arrives in whatever form that takes. So in terms of our operators, typically they will not be, with due respect, somebody at 19, 20 or just out of school. They will have some life experience because this job is not for everybody, no more than frontline clinical staff. This job requires cool, calm, collected, and have the ability to reassure and provide peace of mind and be genuine. Speak to people like you would like them to speak to you, and that's our mantra. So technology is a fabulous enabler, but the people piece is critical and can never be overstated. So I think that's a reflection of our average age of staff member will probably early 40s. So again, it's the life experience piece, and it's difficult to put a price on that, to be honest.
Right. So now we're going to do a disruptive technology demo. By the way, the device I was wearing earlier is called Aware. It's manufactured and designed in Aberdeen. It's absolutely a great device. But what we're going to show now is truly disruptive. How many of us know of parents or relatives that actually had a fall and weren't discovered, and sometimes the consequences were a fatality? So James, do we so I was given this morning. It's Pan. It's manufactured by an Irish company called Pandu, and I think it's really revolutionary. So can you describe what we're going to do?
So I suppose one benefit of the pandemic was that we got a significant time to develop this solution effectively with Pandu, a technology partner. We get a lot of approaches, I suppose, with similar type devices. The benefit of this particular device is they have developed fall detection is not an exact science, as we all know, and this device, I'll hasten to add, is not a panacea. But what it does, it provides reassurance to both family and to the wearer that help is always available. So this device is suitable for someone who's prone to falls, someone who may be in early stage dementia because of geofences, and it has a panic button built into it. It's fully speech enabled, which you'll see very shortly. So it has a wide range, and it is very cutting edge, to be frank.
Right. So we're going to simulate a fall. I'm just going to chuck the device in the air, and let's hope I don't hit the ceiling.
Maybe we should have Paul Flynn done that.
So now it has detected that a fall has been detected, and it is sending the signal to your centre in Bunclody.
So that device obviously has a SIM card. It has a roaming SIM, so it roams across all networks, and it enables a call into our monitoring centre, at which point the location of where Martin is and the type of activation it actually is. So it should say he's had a fall, and our operator will take the call from here.
So it's now saying SOS calling.
It's reassuring the person as well that help is on its way.
While we were in Bunclody, a lady I think in Enniscorthy fell outside the church, and there was immediate communication. Mrs. Murphy, you've fallen. Are you okay? So we're still calling.
So I think the fundamental difference is that traditionally fall detection would have been something that was done within the home. This operates anywhere we have mobile coverage. And typically this should also pick up Wi-Fi within a room or a facility such as this.
I'm good. Sandra, we're standing here. You're actually talking to 100 or 150 people, and how are you?
I'm very well, thank you, this afternoon. And you've come through there on the app and what I've fallen earth. And it's showing up there for Workspace Hotel in Work.
Let me just confirm with the audience, is this the Bridge House Hotel? Yes, no, we're in the Bridge House Hotel. Well, Sandra, this is absolutely amazing now. We are obviously simulating a fall, but this kind of capability is remarkable. You know what, we had Professor Colin talk about 100x experience, and this absolutely is 100x experience. But imagine the power of this device distributed across you know, the country, and you know, the reassurance and the immediate help that's provided in case of a fall. Really remarkable. So Sandra, we'll let you get back to helping real people, but thank you for taking my call so promptly, and I hope I won't be wearing one of these devices for a couple of decades, but I will certainly want one.
Hopefully not long, but we're always here anyway, 24 hours a day.
Great, and how's the weather in Bunclody today?
It's very nice down here, the sun is shining down here. What's it like in Tunstall?
It's really nice too, yeah. But we're stuck indoors.
Well, it's all week for the moment. Shift and shock and stuff.
Brilliant, brilliant. Thanks so much, Sandra, and have a good rest of the day.
Okay,
Thank you. Thanks, Sandra. So again, I think this is a real disruptive capability. It's Irish technology. It's a project with the county councils. We did have Councillor Michael Sheehan ready to talk this morning, and we had a great discussion at the awards. And just to mention, this was nominated last night for the Best IT Project, and unfortunately Connor McGuigan, who we also co-nominated, won, but it's a fantastic project, brilliant OI2 example. So you're going to launch next month in all of CHO5 and hopefully later in the year, maybe across the country. And I think one of our recommendations will be from this council to get this broadly adopted across the country. So thanks very much, James and Catherine.
Thank you, Martin.
So we'll keep going. Again, we are obviously not doing great on time. Delighted to welcome Sarah Jane O'Dwyer to the podium. And we're going to see another really cool demo, and actually Michael Porter and Elizabeth Ticeborough talk about value-based competition. What we talk about is value-based co-opetition. And you know what, Sarah Jane is a nurse by background, but we're going to shortly, well, I won't give the game away, but we're going to do something very interesting here. So Sarah Jane, welcome, and you're just down the road in Carlow as well. So tell us a little bit about what you're doing in Carlow, and you know, what we might be doing, for example, with long COVID.
Thank you very much, Martin. Thank you, everybody, for your time today. I suppose what we've been listening to all morning is all the different products and all the innovation that's happening all across Ireland, and I'm coming now to you as the CEO of HaloCare. HaloCare, you know, to me is a kind of the missing part, is the integration bit. We have, you know, we provide a service at the moment to older people so they can live independently in their homes, and we are diversifying now into a whole clinical space, and that's what Martin was referring to, the living lab, where we will be co-designing with the HSE service for long COVID patients so they can manage their symptoms independently in the community. We have 3 pillars in HaloCare, and they are clinical, social wellness, and the safety. So if you imagine that you go into a hospital, the first person you'll meet is probably, if you end up in A&E, is an A&E nurse, and she's going to do a full assessment on you. Then she's going to see, do you need SLTs, speech and language referral, do you need a physio, do you need an OT? Do you live independently at home? Do you have supports? Do you have a circle of care that's there to support you in your daily lives at home? All of these things create a holistic picture of the patient before they're admitted into the hospital. And that picture is then presented to the physician. The physician then is able to make decisions based on all of this information. We don't admit a patient into a hospital, we're just doing a set of vitals. We want the full picture of that patient to present it to the physician. So that is exactly what we're going to do in HaloCare. We have the technology, we have the devices, and we also have an incredible care hub based in Carlow, which we are going to go live to now and show it to you. And in that care hub, with our MDT teams, with our clinical excellence teams, with our physicians, our nurses, we can then provide that service that you would normally expect in the hospital. So as that lady rightly pointed out, you know, chronic disease management is a major issue in the hospital. And even now, today, if you look at the numbers in the HSE yesterday in the news, and you're looking at, you know, the COVID presentations in the news, which are spiralling, These poor patients have been waiting for the last 2 years, and suddenly, whatever their disease management was has been exacerbated because they couldn't get in and see their clinician because everyone was in lockdown. So therefore now they're at a much later stage when they're presenting to the hospitals. Our proposition to both the government sector and the private partners is that there's a certain percentage of this cohort of patients that can be managed independently in the community using our services. Do you want to go?
Great. So I'm wondering now, Conor, if we can go live to Carlo, to Niall Kelly. Hello, Niall. How are you? Good afternoon. Are you on mute? Can we just unmute the link? Sorry, now just bear with us. Can we rehearse this a number of times? Great, we can hear you. Good afternoon.
That's great. Thank you very much for the link. Thanks for sorting out that issue. Welcome to another part of the sunny southeast here. It's a fine day down here. Hope it is in Tullymore too. So yeah, we're here in the Halo Care Care Hub here in Carlo. Halo Care closely related. In our previous life, we had a company called NetWatch, where we built 8 monitoring locations around the globe, monitoring over 300,000 individual premises. So this centre here is dedicated completely to the care of people, not particularly assets. We've built this centre to the highest international standards, so the highest international standards of resilience and redundancy. With our background in security, our mantra is we will never miss an alert or never miss a signal, and that's crucial obviously when we're connected to so many devices where people's lives are depending on them. So what do we do here? Well, we monitor devices installed in people's homes, monitoring a range of different scenarios. These sensors are all wireless, and in some cases, in a lot of cases, they're unobtrusive, and we rely on, in most cases, non-contact type devices. So our fall sensors, for example, are built into the fabric of the house, and they're scanning each room, looking for the size and shape of a fall. While wearables are great and great technology, sometimes we do feel that people don't like to wear wearables and don't like to have devices attached to them going around the house. A lot of other stuff then that we're looking for, things like activity. So, step count, motion, the type of motion. Is someone sitting down? Has someone gotten out of bed today? Have they stayed in bed beyond a certain time? So the algorithms in our software are looking for any outliers beyond what is the norm. Presence, location in the house, voice-activated panic detection, GPS wandering outside of the house, doors and windows left open, epilepsy sensors, things like gas, fire, and flood. So we're looking at all this data together, looking at things like appliances. If you take an elderly person or a person in their home with maybe intellectual disability, if their normal routine is to get up every morning by 9 o'clock and use the kettle by 9:30, if that hasn't happened today by 10:30 or 11 o'clock, then we should have an alert raised and be able to receive those alerts here in the hub. And the last section, which is the clinical monitoring, which is the ability to use predominantly non-contact devices to look at heart rate, obviously things like pulse ox where you're using a device, weight, blood pressure, stress, blood sugars, temperature, and then a medication adherence device or a medication dispensing device. So all that lovely technology that you can see on the screens comes back in here into our Aura platform, where we're using artificial intelligence to look at the rules for each person's system. So linking all those 20 or 30 pieces of data together, it's an open system, so we don't mind what devices we use. We're happy to talk to someone, whoever has the best remote blood pressure sensor, whoever has the best pulse ox sensor. We'll integrate that using open APIs into our software here. We're looking at the signals in real time, looking at the historical past obviously as well, and then knitting that together in theory to even form some type of predictive analysis. So looking, for example, at someone's weight, their weight loss, maybe their step count, small stumbles or trips that they have over a period of time, which could indicate something bigger happening down the line. And obviously linking that in with clinical data, like blood pressure, maybe for example pulse ox, knitting that together and saying, hey, we may have an event here in a period of time. All that technology is pretty useless if you don't have the right people as a previous speaker has said. So, you know, people like Chloe here, at 3 in the morning, they're the face of this company. You can have all that technology making decisions, but this person here has to be able to speak to that person who may be in trouble, who may have an elevated heart rate, who may have some issue with blood pressure, who may feel weak, who may have not been able to get out of a chair or get out of a bed, or, you know, maybe, for example, left an appliance turned on. Putting all that data together, and these people then making a judgment, using technology as a backup, talking to that person, reassuring them and making sure that everything is okay. That's our mantra, that's our mission, and thank you very much from Carol.
Great, thanks, Niall. And you know, we had the opportunity to visit, and you know, Niall and David Walsh were the founders of Netwatch. You might have heard of the Netwatch Park in Carlow, hugely successful, and you know, bringing Sarah Jane in and Johnny Walker, you know, the radiologist from Hermitage, you know, very effervescent, Aussie and entrepreneur. Like, there's a great team. So I think we can say, actually, people, when we talk about the Southeast, there's an issue with kind of industry, and I think potentially the Southeast of Ireland actually could become a global hub for these kind of services. So, and it's being invented right here in Ireland. So thank you so much, Sarah Jane and Niall, and a shout out to David and to Johnny, and thanks for being with us here today.
Thank you very much, Martin.
Brilliant, thank you. So we said showing up is 50% of success. I'm really delighted now to introduce Professor Peter Weimersheimer and Karen Kelly. Peter has travelled from Vermont, and he has, you know, been a clinician for a long time. I'll let Peter actually tell the story, and then I'm actually going to be a live, well, not a cadaver, but a live example. And what we're going to see is one of the world's most, or leading portable handheld devices, which is 10x cheaper than what is currently being used. So over to you, Peter, and thank you for travelling such a long way. You know, some people have come from Letterkenny, some people have come from Kerry, but you actually came from Vermont, and Russ came from Florida, so we really appreciate it. Welcome.
Thank you so much. Hi, everybody. This is amazing. So I'm a clinician. I did emergency medicine for 25 years. And what's wonderful about this is, you know, for digital health, for me as a clinician, for all of you really, health is about, you know, what we're doing in our community in terms of trying to advance healthcare. And I was going to frame a little bit of what I'm really excited about to bring here. A couple cases. So, 63-year-old man goes to an A&E. He had chest pain for 10 minutes. And he shows up just to get checked out. So he sees a provider. This could have been also in a GP setting. He has normal vital signs. He has a full normal exam. He has a normal ECG. The provider orders labs, including a cardiac biomarker. It's negative. And the standard is to maybe wait a few hours or 3 hours and recheck that lab. And then if that was negative, he was going to go home for outpatient follow-up at some point. But it happened that that provider who didn't do ultrasound signed out to a physician who did ultrasound. So the lab came back normal. The physician goes in the room and says, I'm going to take a look at your heart with an ultrasound. And when he looks at the heart, he sees a dissection flap. That means that the gentleman's aorta from his heart to his body had torn. And discharge home means that's a death rate of 2% an hour. And instead he was admitted, had surgery, and had a great outcome. A 38-year-old woman goes to see her GP. She's been a little short of breath, feeling a little funky. So the GP checks her out, normal vital signs, normal exam, does a negative COVID, says this is probably a cold, go on home and see how you do. She comes back 2 days later not really feeling well. So the workup changes now. And so the exam is normal, the vital signs are normal, but an x-ray is ordered that's negative, a bunch of labs are ordered, they're negative, and the GP starts this patient on some antibiotics, maybe for bronchitis, and sends her home. 2 days later, she comes and sees me. Now, the way I practice, instead of using a stethoscope, or instead of using labs, or instead of using an x-ray as my first way of assessing a patient, I use this, a handheld ultrasound. And by ultrasound, within 2 minutes of arrival, she had fluid in her lungs were congested, her heart was enormous, it wasn't pumping well, so she didn't have COVID, she didn't have a pneumonia, she had what's called a dilated cardiomyopathy and needed to go to the ICU and be on a transplant list. completely different diagnosis. So ultrasound is not new. Ultrasound's been around for 70 years. And clinical ultrasound, I've been doing clinical ultrasound for 25 years. And one of the questions that we've asked, those of us who've been involved in clinical ultrasound, is how come this device or devices aren't in the community as much? How this is so powerful for changing how we assess patients. And what we know is that if a patient accesses the healthcare system, 80% of the time they're going to get a test. And the reason for that is that the provider who accesses that patient is using clinical skills and a technology, a stethoscope that was invented in the 1800s, early 1800s. So 200-year-old technology is being used. And so, of course, to get more sensitivity, they'll do testing, but the early tests also aren't very sensitive. Oftentimes, early labs don't show up anything. X-rays are relatively insensitive for respiratory disease. A chest X-ray for heart failure is only right about 50% of the time. And for pneumonia, about 60% of the time. So it means a third of the time an X-ray is ordered for pneumonia, it's negative. And what we also know is that if a provider takes an ultrasound at the bedside when they start assessing a patient, 50% of the time that changes management or changes the diagnosis. Something different happens half the time because they looked. And so the power of that is incredible. And so the question is, why has ultrasound gone into the community? Well, the technology, until recently, hadn't changed. So for 70 years, ultrasounds have been based on vibrating crystals to make sound waves. And those are expensive to make. They're very fragile. And a normal floor-mounted ultrasound system costs anywhere from 40 to 100,000 euro. And that really prohibits how they can be purchased, where they can be placed. It also is a workflow that doesn't work very well. Sometimes it's hard to get a system, or you can't find a system when there's a patient to be assessed. And certainly in rural health or home health, that's not feasible. So what's the difference about this? This is digital. So this is ultrasound on a chip. There's no crystals here. It's a digital system. And what digital means is, number one, it's really affordable. This is about a little more than 2,000 euros. It's also incredibly durable. There's not those fragile crystals that will break when you drop the transducer on the ground. And this gets dropped. It's an equipment. But what's most important for me as a caregiver is that this one transducer does whole body scanning. So that means when I walk into a patient's room and I don't know even what the issue is, depending what I'm told, I can choose an application on the app for this device and check that patient out for that issue. So whether it's respiratory, or chest pain, or flank pain, or abdominal pain, maybe they have a rash, they're concerned about infection, I can change the settings to look for that particular question. And so this is transformative in that it allows a provider, any provider, so this could be a home health, primary care, community hospital, tertiary care, that initial assessment to use a little more accuracy. The other thing that's been really important for us in our ultrasound systems is that the images from this device go up to a cloud. They're available up in the cloud. They all go up. They're not stored in this. They're not stored in the iOS device, an iPhone they just plugged into. And what's important about that is those images now can get pointed to the national EMR. They can get pointed to a national PAC system. And those images are now available for wherever they were approved to be reviewed by somebody else. So there's downstream patient management. And the final thing, I've been involved in ultrasound education, is how do you train people on how to do this? This is more complex than a stethoscope. So it takes more training, and because that cloud's available, we have educational software, but I can go and look at someone's image from hours away and help them with scanning or critique what they've had for scanning, and just change how they practice and support that, and it's hard to do that, especially in rural communities. So for me, in 2022, again, clinicians are using a 200-year-old technology to do their initial patient assessment. So what does shift left mean to me is that something like this should be normal part of care and normal part of patient assessment. And by staying left, it means that the images exist in the system so that the patient care longitudinally just based on that initial imaging set. So I'm going to set the scan. We have a 3-minute video.
Okay, great.
Cool with that video, and I'll start going with this.
When you give someone the power to see inside the body, you give them the ability to diagnose things and see things that they never would have been able to before. This is going to allow them to save a tremendous amount of lives. When we launched the Butterfly IQ, put powerful medical imaging capabilities in the hands of doctors all over the world. And with the IQ Plus, you've now made it even better.
We listened to the doctors and responded and said, I would like it to do more of this.
We've increased the resolution, we've added more beams, there's lower power, longer scan time, it's going to be easier to get this data. I mean, it's just going to be powerful.
We've been able to increase our scanning rates by up to 60%. And this is what's given us excellent image quality and higher frame rates, which is very important for things like cardiac imaging, for example.
And with those faster frame rates, we get better image quality in the walls of the heart itself. So we can pick up sensitive changes and wall motion abnormalities. Another exciting invention with IQ Plus is something called NeedleViz. And it lights up the needle bright blue as it's going into the skin, so you can really see it, whether you're putting in an IV, injecting anesthesia around a nerve. To be able to see the needle as it goes through the tissue light up, it's something physicians are going to love.
And if that wasn't enough, we actually made the chip even more compact than it was before. When you place this probe down on the body, whether it's between the ribs or elsewhere, you can spend a lot less time searching around to try and tune the image. You just pop it down and you get the image you need. That chip is incredibly powerful. It's making about 500 billion operations per second.
What used to take, say, 10 seconds to scan a bladder, we can now do this in 3 seconds. So going forward, I just see the sky's the limit.
I mean, I'll never forget the day that I got the first message from doctors using our device. And I saw the message that said, I used the butterfly IQ to save someone's life today. And that was a big, powerful moment for me. And now as we've been selling more and more of these devices, those stories keep coming. It's a huge motivator to keep working on this.
How do we change the lives of people we love? This ultrasound device can change the way healthcare is delivered. When a rapid diagnosis can be made, treatment can be started earlier, and people get better faster.
Great, Peter. So we're going to do a 15-20 minute demo, is that right?
We'll do a 15-20 second demo.
Okay, great. So what do you want me to do?
So up here on the screen, you can see this is an app. It's on an iPhone. This plugs into an Android and iPhone. And basically, once it's plugged in, I'm an operator. You can see there's some sort of ultrasound thing here, but I can change whatever presets I want. So you're short of breath, right? So I need to look at your lungs. You've been having it. So I've changed this to a lung preset. So now this has been optimized, and I can take an Alpus transducer, and I always walk around with gel.
So before I expose myself, and the
80%.
Yeah, there is no charge for awesomeness or attractiveness.
So again, the norm is that someone listens with a stethoscope. And why they listen to someone's back with a stethoscope for an adult, 95% disease, right? So instead, I'm going to go ahead and brighten this up for you. And you can see right here that there are those horizontal lines. When those horizontal lines are there, those are called A lines, and that means that's clean lung. So that can't be an ammonia. It's not CHF. It's not a pleural effusion. It's not COVID. It's normal looking lung. There still could be a blood clot in the lung. We can talk about that. So I've just looked at that side and it's negative. So sir, that one looks great. I'm gonna look at this side over here, and guess what? Everyone can see those horizontal lines, right? Is that normal or abnormal? It's normal. So in 2 looks at the posterior lung of an adult, the likelihood of Martin having any lung disease that's peripheral is almost 0. This approaches the sensitivity of a CT scan. It's the same sensitivity. So the idea, now of course I'm trying to figure out how to wipe this off here. I'll do it really quick. So let's say Martin had kidney pain, right? He had flank pain. So one of my questions is this going to be a kidney stone? I can just take the same device and I'm going to change this to an abdominal setting. So now this is optimized to see a kidney. See if you have a kidney. More important how big it is because no one's gone to the bathroom this afternoon. Anyways, so it's emergency department humor. It's going to do for life. And now I'm looking around. Don't try this at home. So there's a kidney right there. Right, and I can adjust this, I have the phone over here, but I can go ahead and use the device and just how I'm seeing things and then get more clarity. And I can do anything that I need to do. There was the issue with falling. One of the things that we did in our A&E as a project, unfortunately when elderly patients fall, they get hip fractures. And so this device has a procedural guidance setting, so we would have, I'll get that for you. We had a protocol that if an elderly patient came with hip fracture, I could take this, I could take a preset, and it's for, basically, I can go ahead and use a nerve preset here, and we would do regional anesthesia and put a nerve ball in. And so this person who had just fallen, had broken their hip, horrible event, maybe life-changing, at least we can treat them and have the pain go away. So this is incredibly versatile for them. Because it's digital, this has AI, and that's the inventor of the device was in it. It keeps on changing. It's like Christmas. Like every month you get an update, and now it does this, and then it does that. And so this does bladder scanning. We're partnering with Captain Health to do all sorts of advanced cardiac AI. And so the idea is that it's easy, and this can go into the home. It can go into primary care. It can go into any device. We use it in pre-hospital, and it's all linked so we can educate all those people. So, here can I answer questions, or?
I think we actually probably have to keep going. That was absolutely. So, aligned with this, actually, I'd like to ask Karen Kelly to come on stage. Thanks so much, Peter. And I think this is a 10x, 100x technology, and I think one of our conference recommendations will be the adoption. I'm so pleased to meet Karen. When I was at Intel, lots of innovation came from the edges, and we met Karen maybe 6-8 weeks ago. And what Karen has done, sort of as a nurse on her own, with a chronic disease, heart failure, is absolutely amazing. We agreed to meet, and actually Karen said, well, can we meet at 7? And I thought that was kind of a bit strange. And when we had a really good meeting, but then she said, well, I'll be here till 11. In fact, I'm here every Tuesday to 11 just working on the paperwork. But Karen has actually done sort of translational innovation, patientMpower, and I think Colin Edwards is here. So Colin, if you want to join us very briefly. Karen has taken a product that was designed for respiratory monitoring and is using it for heart failure. She did it on her own. The results are amazing, and I think you're such a role model. And we will be promoting you across the network. Who's going to be the next Karen? But tell us about what you've been doing.
Thanks, Martin. And thanks, Peter. I've got a new tub, so I'm very happy. My name is Karen. I'm an AMP working in the Midland Regional Hospital in Portlaoise. I'm very, very lucky that actually it's an amazing team. We have a very innovative Director of Nursing, Sandra McCarthy, and a very good team, so we're able to bring in new things into the place. So at the beginning of COVID, we couldn't see, there was only 2 of us in the heart failure unit. We had about 500 patients. We couldn't see them for different reasons, so we had to look at different ways. So I talked to patientMpower because I could see that they were using an app for remote monitoring of respiratory patients. We needed weight and we needed blood pressure, so we have a good disease management program anyway, and we just added the remote monitoring to it, and we started last April with 5 patients. We've now got 84 patients on it. Of that, I looked at about 72, just for quick numbers, that are on it for more than 60 days, and of those 72, 84% came in post a decomp, so elevated pro-BNP, average age of 70, and the EF, which is their ejection fraction, was all quite low. It was less than 35. We've had, of that 1 admission, we've had 27 weight alerts that resulted in decompensation. I'm very privileged to have been taught how to use the point-of-care ultrasound. We have a €45,000 machine, not this little €2,500 machine. And all of those 26 were brought in. They got a point-of-care ultrasound and a pro-BNP, and they were all wet. They were treated as an ambulatory and an outpatient with metolazone. We didn't even do IV diuretics, so it was just medication. And then 3 or 4 days later, you can keep an eye on their weight, you can keep an eye on the blood pressure via the app. Patients absolutely love it. Family members absolutely love it. We only had 1 patient who had to be admitted, and she was a 95-year-old with severe aortic stenosis, so we weren't going to keep her at home. she needed to go up to James's. But between the remote monitoring and the point of care ultrasound, it's really changed the practice for heart failure patients, because the patient comes in and they're dyspneic, you stick an ultrasound on them and you can see within a second whether they're wet or whether they're dry, so you know the differential diagnosis for dyspnea. But yesterday, I just want to, just on this, I've been playing around with it, and I had a 95-year-old lady came into clinic yesterday in a wheelchair, and I'm trying to use this side by side, so we're looking at Living Lab to see if this is as good as the €45,000 machine. And I had the lady in the wheelchair, and one of the things that Peter didn't tell you is there's a button on this that you press while it's in your hand, so you can take your image. So I was using my machine and leaning over the patient in the wheelchair and trying to lean this way to take an image, whereas this one, I had it in my hand and I just pressed the button. And it got the same images, to be honest. They were as good as the ones that I was getting from the machine that I had. So I'm really looking forward to trying this. And I think we're doing very well, and we're keeping our patients out, and we're all happy. Families, carers, they're all delighted, but it is part of a disease management programme that we've just added to it.
It's really amazing what's going on in Portlaoise is fantastic, and I just can't admire enough what you've done, and you're doing 2 or 3x volume of the patients. You're also keeping them well at home, avoiding those readmissions. It's tremendous. So I think another recommendation will be that we take Karen's solution and see how we can scale it, and then we look at it. It's very important. I think Peter, you and Dr. O'Reilly have a short conversation at the break and see how we can advance. So I think the adoption of this, it's a 20x, it's a 50x, it's a 100x technology. It could change care, and it's the power of digital. I'll leave the last word to you, Colin, just sort of for 45 seconds. Your thoughts, the respiratory product, which we work together to deploy within a week, reuse in another setting. It looks like it's a platform that we could use.
Yes, we're mostly working in respiratory disease, primarily interstitial lung disease, but also following up patients post-lung transplant, and building up a body of information that remote monitoring. Number one, the patients who use it do seem to like it. The clinical centres get value out of being able to see the data in real time. Less visits are required without compromising quality of care. It's important to, I think, constantly measure the efficacy of what you're doing and the value it's bringing. And I think the next step is there've been so many good concepts demonstrated here. It's actually trying to get them implemented and woven in to care in a way that really brings the maximum benefit. And it's really important, I think, to constantly measure the efficacy of what we're doing.
Brilliant, and we're integrating all of these into an emergent architecture. So I hope sort of 6-9 months a year we actually have a pretty stable platform that we can deploy across the country that does all this kind of work and then is exportable. So please thank Peter, Karen and Colin. From Grant Thornton, GT have been a great partner with us, and they have sponsored the whole conference. On behalf of the Irish Digital Health Leadership Steering Group and HSC Transformation. Now we have to sort of improvise in real time. We have another really cool demo that you're going to want to see. So I'm going to ask actually two sports stars in Ireland just come up and say a few quick words. Is Gordon here in the room? Gordon Darcy. Great, so Gordon is working with his sister Shona Darcy, doing some really interesting work around speech therapy and waiting lists, and Gordon's also agreed to be a spokesperson for us in terms of, because one of the things in socializing this whole story is actually reaching out to the ordinary people, and we're really blessed. We have Brent Pope as well, but I think you charge more than Brent actually. But we have Paul Flynn, and we potentially have Tyson Fury, but he's a little bit busy with a fight at the moment. So over to you, Gordon. Thanks for making the time today.
Thanks very much, Martin. I'll try to do what you said you've been trying to do all day. That's been brief. So I got one of the full medical supports up in the back room earlier, so that's great to see digital initiatives in practice. So Martin said, my sister and I, who's at the back of the room there, we are a digital health company called Kids Speech Labs, and we're bringing pushing technology into the area of children's speech and language therapy. Martin also asked me to kind of talk about a bit my experiences in from sport, and I suppose how it can apply into the shift left and stay left. And I suppose the very clear message from my experience would be that if we don't stop and accept that there is a problem, it's very, very hard to go forward. So this happened in sport, and a number of teams that I played in, very, very talented team, that perennial underachievers, until we stopped and actually talked to each other and accepted that we weren't all doing our best for the team, till we addressed, or as we in sport like to call it, driving the elephant into the room, not just addressing it, that we weren't able to go forward. And it's a little bit like this in digital health, in health in Ireland. I think Martin just said we're 80th in the world for health, and in our vertical there's 45,000 children sitting on waiting lists for speech therapy in Ireland. That's increased 30% in 12 months. I think one of the speakers talked about just hiring more people is lowers the standard. It doesn't deal with the actual issue. So unless we stop and address and accept that we have an issue, it's very hard to plan a consistent route forward. The next bit about that is, I suppose, it's an attitude to failure. And in sport, that's one of the most debilitating things. If your attitude to failure is that you don't make any mistakes, then you actually do nothing. And that's the worst possible place to be. And one of the biggest challenges you talk about when you've earned the right to get to a final of some sort is that you don't freeze, that you make the same decisions that you would have done in the earlier stage. So pressure shouldn't change that. And I think in the real world, what that is attitude to mistakes. And I think if there was a silver bullet in any of the areas that all these fantastic companies are talking about today, if there was a silver bullet to be fired, this man would have fired it, or Paul Reed and HSE would have fired it. There isn't one. So to think that we're going to move forward without making mistakes is a fool's errand. So if we don't change the dial on that, and how we process and how we look at mistakes, we're not going to move forward. I think actually the sooner we make them, the quicker we make them, the more we can move on. This whole agile methodology, and that's really the I suppose the key message for me. And this is what we do in sport, and on a daily basis. I think the bit is about realizing there is a problem, then you can solve, then you can make forward, and then responsibility. And I think that's a key word. And I think it's also, it can be people can look at that with a negative connotation, saying, oh, I might be responsible for that. But you may be, and they view it, say, oh, if it's a mistake, I'll be held accountable. Small mistakes on the way to a big win, you'll also be responsible for that. And that has to be the lens that we look at in digital transformation, and that's definitely the lens Shona and I take in Kids Speech Labs, that we're trying to help every stakeholder along the way. We're trying to help the people that are on the waiting list. We're trying to help the clinicians who are swamped to do their job better and to do the higher value work that they want to do. So I think that's short enough. And Martin, thanks very much, and a brilliant conference. Well done to everybody. Thank you.
That talk in our next staff, and the work we're now engaged with the Living Lab, with Kids Speech Labs, and it'll all be about earlier intervention, quicker progression and waiting list reduction. But before Gordon goes, my son and I are big Leicester fans, so we're going to do a selfie. So.
We only practiced this 11 times.
Paul is from a different code, and those of you that love GAA, Paul is, no surprise, 6 times All-Ireland winner. We've been on a similar journey to the journey we've been on with Gordon, and through perseverance, this is another 10x technology. So, Paul, will we do the selfie first, and then
I didn't think you were a Dublin fan.
I was kind of born in Dublin, but like the lily whites, when I'm thinking of changing colours.
Not just yet. Thanks very much for the time, and thanks very much, Martin, for leading the way and for setting up this conference. Definitely resonate with a lot of things that were said already today, and especially what Gordon said in relation to, I suppose, the synergies between sport and what we're doing here today. But the one thing that I'd add to it is teamwork, because all day long I've been listening to just fantastic different organisations, leaders, and you brought them all together, Martin, and I'd love for that to continue, because there's definitely, you know, a team element to this where we can actually work together to really grow all of our different organisations. So the organisation I'm involved in is Mobile Medical Diagnostics. I'm not sure if the slides are ready. Doesn't matter, I don't like a fellow. We provide a mobile X-ray service, and Cara, who's with us today, she's from the HSE, she's a part of Joe Ryan's team, who are the sponsors of our initiative. So we've been rolling our mobile X-ray service out in Dublin and Cork as of this week. So pretty busy at the moment, but it's all going really well. So we have 2 units on the road, portable X-ray units, and our radiographers take our units from location to location. Nursing homes are where I suppose, would we call it a pilot car? No, we're just working together. We're initially started off in nursing homes, so in all nursing homes in the Dublin ED catchment area, and all nursing homes in Cork, where we go, we bring a machine and a radiographer on site, capture the image. It's then shared with a cloud-based PAC system and reported within 4 hours. So it's a same-day service with a 4-hour turnaround time on the reports. And again, it's certainly in line with the 10x, keeping people out of hospital. To date, under the scheme with the HSE, we've done this year, the last 3 months, we've done over 500 X-rays, and in 88.5% of these cases, we're keeping people out of hospital. So it's been a fantastic service so far. We're as a same-day service, and we're looking forward to continuing and scaling this right across Ireland and into the UK going forward. So. That's great, Martin.
That was brilliant. Wow, that was the briefest, most succinct, you know, thanks so much. Okay, we're going to keep moving. Is Louise still here? Did I see her slinking out? She's gone. Do I see her at the back? No. She's gone. Okay. So what we're going to do now, we have you have one more main keynote. This is absolutely going to be amazing. You know, that expression is a funny story. You know, if we can see more clearly, it's because we stand on the shoulder of giants. I'm so delighted that we now have Jimmy and John Sheehan to give us a keynote. And I had the pleasure to have tea with Jimmy Sheehan, the founder of the Blackrock Clinic and the Hermitage and the Galway Clinic. And we had a fabulous talk, and Jimmy actually made some brilliant sandwiches as well, so I'm hoping to get invited back in. But Jimmy gave me a copy of his book, and I took it home and I opened it up, and on the first page was the quote, "If I can see more clearly, it's because I stand on the shoulder of giants." So we're going to have a unique talk here, so it's really like passing the baton. You know, what Jimmy has done for transforming Irish healthcare is amazing. He did offer actually to build a children's hospital and personally manage it and deliver it on time, and that would have been probably about 8x cheaper. It's nearly a 10x technology than what we're currently going to inherit. So what John is going to do is literally amazing. He's actually he has a beautiful assistant. I bet Gordon Dunn has never played that role before, but thank you, Gordon, for volunteering. So we're going to see something amazing that was created in 2 weeks. So I'll hand over to both of you, and thanks so much for doing this.
Thank you so much for inviting me today, Martin, to talk. It's a great pleasure to address everybody here today. As Henry VIII said to his third wife, I won't be keeping you for long. I commenced my journey in healthcare 66 years ago, so I am sort of very much at the other end of the spectrum to most of the speakers today. You know you're getting old when you're invited to talk about the past, and our partners to talk about the past, so I have nothing dramatic to say about the future, which will be left to John. when I qualified in 1963, that was the year John F. Kennedy was assassinated. Our medical defence fee was £2 Irish at that time. It's now about 40,000 for an orthopaedic surgeon. X-rays are our only imaging modality. We use glass syringes which were reused, washed and cleaned, and needles that were sharpened between use and again be sterilised. We tested the urine with using a Bunsen burner to see if the urine coagulated as to whether there was protein in it. Now, 50 years later, when I finished my practice, these were the modalities that have now evolved. It's quite mind-boggling to think that CT, MRI, PET-CT, wrist, DEX, all these modalities now became available 50 years later. So that really over that time, I had to adapt to enormous change in my practice. And every operation that I trained to do when I qualified was no longer applicable at the end of my surgical career. Everything in the early days was now obsolete. So really we're looking at a very changing, rapidly changing field in medical care. When I graduated, my intern year was at St. Vincent's Hospital. That was the old St. Vincent's Hospital in the Green, Georgian buildings. The wards are Nightingale wards. Nightingale wards, long wards, plenty of light, cross ventilation, and a veneer. And they persisted for many, many years. It was only in the late 1930s that hospital design changed significantly. And it changed because GE introduced the fluorescent tube, and you could now light a much deeper floor plate in a hospital. The windows were smaller, the ventilation was much poorer, so some aspects of design were not as good as previously. And sadly, most hospital design has remained pretty well unchanged since the 1930s. I came back to the staff at St. Vincent's when it opened in 1970. It was spanking new at that time, and it was built, as you can see, as a block structure, the same as pretty well all hospitals are now built. I was privileged to be involved in the design of the Galway clinic in 2000, and this was the first digital hospital in the country. The hospital was designed on a totally new concept, getting away from the block design, because now from the Nightingale era, where the wards occupied 80% of the hospital, we now have the wards occupying only 20%. The rest was outpatients, diagnostics and other services. So the hospital of Galway was designed to optimise the use of natural light, ventilation, but above all for efficiency of staff and wayfinding for patients. Because having worked in hospitals all my life, I found them most user-friendly for both staff and patients. And this is a whole new concept to try and change our concept of hospital design. We set up an innovation centre in architecture. My son Mark was with us here today because he did extraordinary work. 20 years ago we had a full patient electronic record and a huge number of innovations which he was largely responsible for. One aspect of the hospital that was particularly important was centralising everything in a hospital atrium, a very user-friendly atrium, so that everything came together in the atrium, and it was the central point of the hospital. Everything emanated from it. And I'd make a plea that listening to the extraordinary technology that's now available, our hospital structure does not stand up to modern day technology. And we need a huge investment in our hospitals, not just in the technology, but actually in the design and the structure of the buildings. Not just hospitals, but our health centres and our GP practices. They all need a huge investment, and I think it's been very sadly neglected. Now, in the year 1494, Vasco da Gama sailed from Portugal over to India, and in the process of the voyage, 170 of the crew started and 100 died during the voyage from some sort of a bleeding problem which they couldn't identify. Just over a century later, The same voyage was reproduced by Captain James Lancaster. He had 4 ships. On 3 of the ships, 40% of the crew died. And on one ship, the flagship, there was no mortality at all. And when they looked at it, the only difference was that the people on the flagship all were given 2 teaspoonfuls of lemon juice each day. And they realised that whatever was in the lemon juice, it actually turned out to be vitamin C, prevented scurvy and prevented the deaths. It took the British Navy 200 years later to introduce that preventative measure. Such was the rate of change at that time. And to me, having lived through so much change, I think it's so important that we all look at change. You need the will, the ideas, and the execution for change. And if you take anything from my talk today, just remember the motto for the Whirlpool organization in America. It states that, innovation is for everyone, everywhere. It's not for the chosen few or for the few major projects, but innovation to me is the lifeblood going forward of our organization, and no organization requires innovation more than healthcare. Innovation isn't invention necessarily. Innovation is application of inventions. They may be very simple, and the simplest of innovations sometimes are some of the most profitable. The space shuttle on takeoff uses 94% of its fuel. So getting started is the most difficult of all. And no matter what project you're on, getting started is the biggest problem of all. And I'd like to wish Martin and his team every success for the extraordinary work they're doing in reforming our healthcare service. Thank you so much, Martin. I'm going to hand you over to the next generation, and I'm delighted that he happens to be my nephew, John Sheehan, and he's going to talk about the future and much more interesting things than I've been talking about. John, thank you.
Thanks, Jimmy. Hi folks, let me just set up here for a second.
Just to mention, John is the Vice Chair for Clinical for our National Digital Health Leadership Steering Group, and he's brought huge energy to the momentum, and he has a fantastic quote in our press release in terms of this potential to work as a community to change our healthcare system is what gets him up in the morning. But over to you, John.
Thanks, Martin. You're probably all wondering if I lost my marbles. It's all become more apparent. But I do still have my marbles. Now, let me just go on to the slide deck. So good afternoon, everybody. It's a pleasure to speak with you all, and I'm really excited to share with you about really how we can embrace the future of healthcare. And the areas that we're going to look at today are centered around the cloud, artificial intelligence, and virtual reality, augmented reality, and as I'm wearing today, mixed reality. And there'll be an interactive session with our CEO from the Hermitage Clinic shortly. So if I can just go through some very basic things. I like to keep things simple. I think it's really important in life because life is quite complex. And I'm a big fan of Sam Harris. He's a neuroscientist, he's a philosopher, and he said the 2 most important things in life, apart from my daughters Mia and Sophie, are love and curiosity. And everybody should have an understanding of love and curiosity for both yourself, people around you, the life, and the world itself. So this is a really interesting slide that I came across recently, and I think it goes to what all of us do in terms of our work, in terms of what our life missions are. And it's a Japanese reason for being in terms of what actually is the sweet spot to actually achieve optimum satisfaction in what you do with your life. So it's important to do what you're good at, obviously, something that pays and puts food on the table. Obviously something that you love, and ideally something that will actually help people because of the needs that exist out there. So I've been very fortunate in my environment to have a number of those things that have given me a great degree of ikigai. I won't go through them all there, but the specific ones are, I have the opportunity to work in a very dynamic healthcare group, Blackrock Health, mobile medical diagnostics, you met Paul, and X-Wave, as Martin referred to, and now it's exploded into the IDHL SG, where we stay left, shift left, 10X, and leapfrog. So the key thing that Martin has formed this on is the Open Innovation 2.0, which is the quadruple helix, and that's essentially where you, as you know, bring the public sector, the private sector, academia, but also the patient on board, our citizens, our humans, as it has been mentioned. And with the group that Mark has gathered to date, we have essentially the government, the Department of Health, the HSE, all of the academic institutions, and then healthcare, health tech, med tech, big tech, and big pharma. So really this is an opportunity for us to leapfrog by staying left, shifting left, and 10x, whereby we end up with a digital transformation to the world that we live in a positive way. So what I'm actually wearing at the moment is a augmented reality HoloLens Microsoft device. And it goes between the spectrum of the physical world and the digital world, giving augmented reality, unlike the Oculus, which is an immersive device and it blocks out light and you're in a virtual world. So what we're going to be in now in a minute is the augmented reality world. So what are the applications in healthcare? The key stakeholders, the patient obviously, the clinician, radiologist, surgeon, the technology, cloud, AI, and augmented reality, and then obviously imaging such as MRI and CT. The applications specifically are, it can be used to teach medical students, our doctors, demonstrate to patients their pathology, and discuss things with your colleagues, plan interventions, and then ultimately actually to assist you actually do those interventions. So this will all lead to things being 10 times better, faster, and cheaper. So this is an example of the first of two projects that we have essentially done within the last 2 weeks with the help of Martin and a number of collaborations. This is one with Siemens and Blackrock Health Hermitage Clinic. This is our CEO. We scanned him last week on Wednesday, and you can see we did this novel sequence called DTI fiber tractography, which shows all the complex pathways that go from each part of the brain to the other parts of the brain, and then right down to your heart, your feet, etc., etc. So really stunning images that will only get better. We also sent his images to the cloud, whereby artificial intelligence with Siemens AI RAD Companion took his whole brain volume data set and actually analyzed it with huge detail and color mapped his whole brain in terms of right down to the small structures on the left and the right, whether it's the thalamus or putamen, and gave it a volume for each, whereby it then gives you this enormous amount of granular data that allows you to make a very informed decision very quickly and tell you the volume of the ventricles, the lobes, to somebody of Alzheimer's or epilepsy, etc. So I'd just like to invite on stage Gordon Dunn, our CEO and happy volunteer for the demonstration. This is where we've combined the virtual reality or augmented reality HoloLens headset, and will allow us to, for example, plan stuff or do stuff in the operating room. And this is a collaboration that's happened just within the last 2 weeks between Microsoft and Popular and ourselves. So I'm just going to flick over to the live screen shot. And so my slide is still up, folks. what I'm seeing, you're not seeing, which is Gordon's brain, and it's very interesting.
Unlike Martin, I'm not doing a live demonstration.
Literally before I came on stage. It's massive.
John, while you're working away there, I'll just, the whole process for me as the guinea pig was very, very simple to participate in this adventure. And so it's basically an MRI with contrast. I'm one of those unusual people that actually enjoy MRI, and I have on occasion fallen asleep on the dentist chair, so it was painless for me to participate in the whole function. You just keep talking. Yep. Job of a CEO, job of a CEO. So I was about 20 minutes in total on the MRI table with contrast to facilitate, and as has been alluded to, myself and John have discussed this, and it's an interaction between Microsoft, Siemens, and ourselves in Blackrock Health Hermitage Clinic to be able to enable this technology. For us, it's most exciting because we are one of the largest neurosurgical centres in the country and the largest private. So to be able to augment and to be able to use this kind of technology on our patients or for the benefit of our patients into the future and actually in real time as we go through this process at the moment in the hospital is a huge advantage to the patient and really, as has been alluded to, allows us to leapfrog forward with technology and enabling much better, much more specific and much more targeted patient care.
What we might do is the IP address changes every 24 hours in this hotel, and it's just changed. So maybe let me just sort it out and we can be back after the next keynote and just finish off this segment if that's okay. I'm sorry about that.
I have a few songs.
I'm just conscious of time, but I will be back after. So thanks.
Great, and this is the point of IT dial tone that it needs to work all the time, and these little things actually could be life and death. Now there is tea and coffee. What I propose we keep going because we have so much fabulous talent in the room. Maybe could ask Gary Boyle to come to stage and talk for 3 minutes. Gary is a good friend of mine. He's a patient advocate. He's also a West Ham fan, which really puts him up in my book. And Gary was a guest speaker at the Health Tech Ireland Awards, and looking at how technology has evolved. Gary's actually developed an app for the Parkinson's community. Normally it takes 15 months to develop a medically approved app, and he developed it in 2 weeks. So Gary, welcome to the floor.
Good afternoon, everybody. I feel totally overwhelmed by being here with all the talent here in the room. It's just amazing. Don't forget what you're doing here. You're changing people's lives. You're changing my life. You're saving people's lives. It's incredible. I've just been so captivated by everything I've heard today so far. For me, I'm living with Parkinson's for the last 12 or 13 years. This is a rare event for me. I've just taken medication because my previous medication wore off. So my voice is probably going to sound a little bit shaky. I'm not particularly nervous, but I just, Parkinson's, you shake. So, get over it, that's what happens. And I can definitely feel that I'm definitely off. And that's something that I'm not too concerned about because I know I'll come around again. But how long I'll be able to do that, as in for the rest of my life, is the challenge. And that's the thing about Parkinson's. It's a pretty horrible disease. It's horrible in so many fronts. It does this to you. But it gets into every part of your life. So what I've seen today and what I've heard today, and the amazing technologies that are being developed, that are kind of not as intrusive as previous technologies, particularly the thermometer that was demonstrated this morning. I mean, that kind of thing is so brilliant and so simple, and will make such a difference for the lives of people like me living with Parkinson's. But what I've discovered, much more importantly, I think, over the last 2 years, the 2 years of the pandemic, which have been awful. COVID-19 has been horrible. But for me, it has been a bit of a revelation as well. And very briefly, one of the therapies for Parkinson's disease, believe it or not, is Irish set dancing. Now, some people don't know that already, but maybe the rest of you didn't, but it's true. Discovered by Dr. Daniel Volpe from Venice, who has a keen interest in Irish music, plays the fiddle, plays the banjo, plays a lot, and travels to County Clare every year to the music festivals in Clare. And he noticed when he was there one night in a pub in, I think it was in Feet, County Clare, that there was a guy, Professor Daniel Volpe is a neuroscientist, so he knows what he's talking about and he knows what he sees. But he saw this guy at the bar who he could determine clearly was living with Parkinson's, but when the music started, this man shuffled over to the dance floor and then spent the next hour dancing sets to beat the band. And Daniel Volpe was looking at him going, what's going on? And he kind of said to people sitting beside him, what's the story with that man over there? Wait, Jimmy? Yeah, him. Oh, Jimmy has Parkinson's. I know he has Parkinson's, but he's just danced for the last hour. Oh, Jimmy's one of our best dancers. So he thought, what's going on here? So he brought that back to Italy, to Venice, to his surgery. He put 16 people through a kind of a 6-week course of his kind of prescribed Irish set dancing moves, and every one of them improved. Every one of the 16 people improved their balance, their gait, their ability to walk, and instead of shuffling and instead of kind of freezing and stuff like that, they were improving their movement and improving their ability to get around, and it was really sensational. And that's something that was written up in the British Medical Journal. It's there for everybody to see. It's quite an incredible story. Fast forward to today, or to the last 2 years, I'm in an Irish set dancing group. I've been doing it for the last 6 or 7 years, with a bunch of people who are doing it much better than me, because they're probably a little more senior than I am. Parkinson's kind of hits the young onset Parkinson's hits people in their 40s or younger, 50s or younger, and then let's say the more typical Parkinson's person would be somebody in their, let's say, mid-60s and older, and that's what people would normally associate. When my ex-consultant said to me, oh yeah, no doubt about it, you have Parkinson's disease, but don't worry, it won't kill you, I said to him, I'm 44, I'm not 74. And his response was, well, I had a girl in here yesterday from Cork, she's 29, she has had Parkinson's as well, so, you're not so badly off, But the thing is, anyway, we were doing this set dancing, the pandemic came along, cut all the classes, we had to go into, that was the end of it. And for a lot of people in my group who would be in the senior category, they were saying, well, that's that. We'll see what happens. Hopefully we'll be back together again in a month or two. And I was thinking, wait a minute, this is not difficult. We can do this. We can put it online. And a few of us who were in the younger category kind of got together and said, lads, let's put it all online and we can do it with whatever device you have. And that was met with a kind of a curious face. How do you mean? We don't know anything about this technology. And we got with every one of them. We put them through kind of going on to WhatsApp and then moving on to started to use terms that they definitely wouldn't have heard of before. Instead of using Zoom, we use the platform Blue Jeans. So I've had many conversations with people saying, well, have you on WhatsApp on your phone and on your iPad? Because you need to then put Blue Jeans on that as well so you can link the two together. And the look of kind of fear in the person's eyes when I was saying this kind of thing was palpable, So I said, look, trust me, this will work. And it did work. And very simple technology, very old technology, like the video technology that's in Zoom and in Blue Jeans and teletherapy, it's been around forever. I mean, Skype has been there forever as well. But we took that and we applied it to this, and it was a roaring success. It has been and continues to be. And we actually doubled the number of people who were attending the class. Even though they weren't attending in person, like we were meeting face to face like here today, but they were effectively looking at a screen, and they were kind of interacting with the screen, and it was really fantastic. And what was also brilliant was that at the end of every session, we had the virtual cup of tea. Like, everybody could see each other on the screen, and they were just kind of saying, how's it going, and how are things? And we started to talk about things that were affecting us in our daily lives living with Parkinson's disease. And it became almost as important as the movement and the dancing that they were doing. I was kind of moving, you know, instead of dancing. But it was, you know, really as important as that. So I kind of I bumped into Martin, you know, we were chatting about things, and Martin and I worked together in Intel a number of years ago. When I say work together, it was more a case of I used to get Martin to come into my group and talk to them about the future, where Intel was going, while I would stand just looking on in awe at what he was saying, you know, and wondering how he does what he does. It's just incredible. But with this app that we're kind of developing now, it's an opportunity for people to stay connected. It's an opportunity for people to use a device, have a simple app that they can interact with and start building up their history, their symptoms, get all the information they need, have the link to Blue Jeans so they can go back dancing again. Very importantly, have the ability to connect with each other. Because one of the things with Parkinson's is you need to keep moving, you need to keep thinking. And your brain, what's left of it, is really needs a lot of help. And you know, the medication I've taken, for example, is really important to me. But what makes it more effective is the exercise I do and the activity that I'm willing to kind of continue doing. And this has been very important for people who are living with Parkinson's in, let's say, the regular kind of age category. And they've now discovered that this technology that maybe had passed them by is with them now, and they use it. And the best comment I've heard from any of them is one lady told me when I asked her how is she getting on with using Zoom or using Blue Jeans in her daily life, and she said, sure Gary, it's great. I'm getting my pension online now as well. And I mean, I just think, isn't that just incredible? Somebody who wouldn't have known anything about a mobile phone or a smartphone or anything like that is able to kind of interact with something as simple as that. And that's what you're creating. That's what everybody in this room is creating. You're creating that environment for change that we all felt was gone. But I can tell you, it's definitely here, and we really need it. And you know, I've got a few thoughts put together, and Tom Colin from Zendra Health is the guy who's kind of put it all together in an app format, and he's done a fabulous job on it. And we'll keep revising it, keep updating it, and it'll be really useful. But the most important thing is it will keep people connected. The pandemic stopped all travel and stopped people, you know, meeting each other. Maybe they're going to get up in the morning, go out, get the paper, go to mass, come back, sit down, and nothing else. You know, now you can press a button and you're talking to your neighbour or your best friend. People have gotten used to that now. They've gotten familiar with it, and it's technology that is very simple, but it's hugely, hugely impactful in an extremely powerful way. And that's what I'm so grateful to everybody here in this room. Thank you for making my life easier than it would have been with this kind of diagnosis that I've got. The diagnosis is terrible, but the future is, I think, pretty bright. And the last thing I'll say is, I'm not cured, but I am better. So thank you very much.
Absolutely fabulous, and you know, what Gary's talking about actually is Healthcare 4.0, which is Industry 4.0 transferred to Healthcare 4.0, but with patient empowerment and with the community working together. John, how are we looking? Will we keep going? So we are going to, there's lots of people have changed plans, like Roisin Malloy was due to be in Austin today at South by Southwest. She changed her plan. So I'm just going to pick on you randomly and come up and share your thoughts if that's okay. So Ger, would you mind coming up? I'm a huge fan of My Life that Irish Life provided, and you know, I consume it and I look at it every other day, and you know, imagine if this was used across the country, we could have a picture of everybody improving their health and a picture of the national state of the country. So thanks, Ger, for taking the time, and looking forward to hearing.
Good afternoon, everybody. And after those very inspiring and amazing last few presentations, I feel completely inadequate and completely unprepared. And I'm also conscious that it's getting late on a Friday afternoon, so I'll go through stuff fairly quickly. And first of all, thanks to you, Martin, and the rest of the team for organising today and the invitation to participate. Obviously, we're in a slightly different part of the industry, of the healthcare industry, in terms of providing health insurance through Irish Life and obviously the wider life and pensions market. Irish Life Health have been working a lot over the last while and leading the way in terms of developing a range of digital solutions to support our customers and how they manage their health and well-being. So we're coming at it very much from the other side of the fence in terms of the pool of customers that we have and what do we feel that they need and how can they get access to the care that they need. It's probably no surprise to say that we've, over the last couple of years, seen a very rapid increase in the use of all our digital tools, including our digital doctor, of which the volume has gone up by over 100% in the last 2 years. Even things like our mental health supports, all of which are available digitally, and that's gone up over 80%, and we're constantly expanding the range of services you can access through our My Clinic facility, which is a portal that everybody can get on and get to meet a clinician and also get online help as and when they need it. Looking forward, we're very excited to continue to expand the range of services that we have. A number of great ideas here earlier on, and I think we'd love to talk to a few of those kind of people about how we can put them onto our portal. We're also seeing a huge trend towards people wanting to self-serve. So we put a tool up online where people can check are they covered for a particular condition or a particular hospital or a particular consultant. Huge increase and huge adoption of use in that, and really impressively that they didn't contact our call centres afterwards. I know somebody earlier on made a comment around the use of call centres. We're actually seeing our call centre volumes drop as more and more people engage with us online, which I think is a sign of what's going on around the rest of Ireland. Making it easier for customers to access care when they need it in the most convenient way is critical to us. And as a significant funder of healthcare systems through our customers' premiums, putting them at the centre of what we do is incumbent on us, and also making sure that they get what they need and also that we get good value for money, which I think was another theme that was mentioned earlier on. We really believe that having a strong digital engagement really encourages and supports and enhances the physical care, and it's a real win-win both for the patient, our customers, and also the whole healthcare system. To that end, we partnered with an international tech partner to develop and deploy our Irish Life My Life app, which provides personal wellbeing services that motivates you to stay healthy and connects you with your community to continue to foster engagement. Again, it's really interesting, the last speaker just touched on that as well. It's actually about the people and about how you create that engagement, not just about the technology in terms of how you track. On the app, you can set goals, track activity, access a health coach, take part in challenges, even get tips on how to eat well and get better sleep. The app actually produces a clinically validated health score, and that's constantly reassessed across all those activities on an hourly basis. So you're constantly seeing how you're doing across each of the main categories. There are also incentives and rewards to really help people reinforce the healthy behaviours that they pick up through the app, or just decisions that they make themselves. I feel like I should get one of those virtual reality goggles and show you how it's all done, but in the interest of time, I'll move on. We've made My Life available to everybody in Ireland. You don't have to be a customer to use it, and it's readily available on all platforms now for people to go. Martin, thanks a million for downloading it. That's good to hear. We've over 160,000 people have registered to use the app already, and over 60% of them are not customers. So people are just taking it, using the app, and we're really delighted with that in terms of seeing the use it's getting beyond people who have business with Irish Life. I must say, I'm afraid I do have to be a customer to get the physical rewards. So you can get lots of physical gifts, vouchers, you can make charitable donations. Again, that's all about trying to get people motivated to continue to engage with the app and invest in their health and wellness. Maybe just to give you a sense for what we've seen in this, we've just finished our annual GAA Healthy Clubs Challenge, which was done as part of the wider Irish Life. And this is the 7-week challenge, and it's geared towards clubs in the GAA community. Clubs are asked to hit a collective target of 4,000 kilometres each, and there were provincial prize draws and a closing event in Croke Park which added as motivators in a community that is not afraid of competition in any shape or form. We thought there might be less participation this year because of the relaxation of lockdown restrictions. There was great engagement in 2021. We were a little nervous this year, however, the participation was even higher. We had nearly 29,000 participants from nearly 700 GA clubs right across the country got involved. And some other interesting statistics that came out: the average person walked 5.2 kilometres a day, which was 1 kilometre more than they did the previous year, which is great that people were actually engaging with the programme and seeing the benefit of it. I think this year we had 5 million kilometres tracked, and a total for the absolute statisticians among us, that was 7 billion steps in terms of what tracked through the app. So it's getting great engagement, and you get great feedback and great information out of it. And one other interesting aspect around My Life is this health score. So when we look at the improvement of people's health score over that 7 weeks, it actually improved by 10%. So again, people were seeing real tangible benefits coming through in terms of how the app was scoring their health. As I'm sure this audience will know better than me, all the scientific evidence suggests that this will have a long-term health benefits for the participants themselves. Obviously, because we're doing this through the club environment, a great social engagement as well, so it's really helpful in terms of their mental health. And we're actively looking at ways that we can scale the level of participation and engagement that we can generate through My Life. I would encourage all of you to download it now, if the hotel Wi-Fi will allow, and give it a go. And there's nothing to be lost by just trying it. We believe that digitalisation gives us the opportunity to radically improve effectiveness both in our main business, about how our customers access healthcare, but also then how we can encourage people to make a difference in terms of making decisions about their own health and well-being. It's really all about keeping people healthy, and when they need care, getting them access to the right diagnostics, care at the right time, and without necessarily overloading the hospital system. Again, it was a very common theme that struck me when I was listening to various presentations this morning. This is not about trying to do something different. It's actually just about trying to get people well, and also get them engaged in the health and well-being, so we can keep them on the left-hand side. We see our role as assisting and guiding our customers and the wider population as they manage their health and well-being, as well as our more traditional role of funding the more significant interventions as and when needed. So, in the spirit of trying to keep it short, I'll stop there. Mark?
And Irish Life Health have been really innovative and really collaborative, and they have a fantastic lab actually down in Talbot Street that we've looked at, and they take all the principles of agile software development, and it's a brilliant environment. So we look forward, maybe one of our recommendations could be the adoption of something like My Life across the whole country. And one of the reasons I think it's attractive to work with Irish Life Health is, some of you who follow economic theory, the economic mutuality is now becoming a major force where companies are shifting from, well, the authors of a recent book talk about a shift from profit to purpose, but you can't do that. You have to have profit and purpose. But the theory from about 50 years ago that the purpose of a firm is to maximize shareholder value, that is starting to decay and fall apart. So John is still working on the technology. I suggest, is Dr. Orla O'Reilly still here? Okay, I don't know, Orla may have just had to left. Jim, I think we're going to go live to Professor Ken MacDonald of UCD, who's been waiting patiently online, and then Caroline Whelan, is Caroline still here? She may have had to leave. I know she was telling me she had one of her daughters to pick up from hockey at Railway Union, so apologies, Caroline. Great, hi Ken, welcome to the sumptuous Bridge House Hotel in Tullamore. You're live in front of the audience. We've been building a collaboration around how could digital impact heart failure and cardiovascular, and you and Matt Barrett actually have been a pioneer in this area in terms of virtual care. So maybe you could share your thoughts on what we've been doing, for example, with capability maturity frameworks, where we might go in the future, and potentially what we might do around a research center and so on. So thanks, Ken.
Thanks, Martin. Is there an echo at that end, or is it just a by end?
I I think it's just at your end, Ken.
Okay, that's fine, that's fine. Once I'm coming through loud and clear, thank you, and again, apologies I couldn't be there, so it became a bit of a mess of a day for me. And fantastic gathering, and I've been listening into this, and it's really exciting times, not just for cardiovascular medicine, but I think for healthcare delivery in its totality. And again, I think many of you in the room would have been, if I can use the word dabbling or the verb dabbling in digital health platforms over the last 2 decades. That's certainly what we've been doing in St. Vincent's, and making some inroads, but in general the environment for this development, especially in the early part of the century, wasn't optimal, I don't think, for digital healthcare initiatives because of, as I say, the fundamental background type of service that we've had. But the encouraging thing is this is now changing. I think this is one of the major issues that we need to take into consideration as we look towards the benefit that digital health can bring to healthcare delivery in general. And that is the changes that have been initiated by the health services, the health service executive, particularly in chronic disease management. And it's in this area of chronic disease management where I think we're going to see the maximum impact of digital platforms. And again, as many or all of you will know, that the HSE have rolled out this concept of integrated care for chronic disease, and they're focusing in on cardiovascular disease, respiratory disease and diabetes. And I believe that this structure, and again, the HSE are to be credited for putting enormous resource behind this development, but it's no longer a plan. It's now actually, since the start of this year, and Matt Barrett is leading out in Vincent's and the other units, developing it now across the country. These are now in action. And this type of integrated care service in the community, linking the community to the hospitals, will bring significant improvement to healthcare and chronic illness. But more importantly, from the point of view of this particular conference, I think it provides the ideal platform to truly test the incremental benefit of digital platforms for not just cardiovascular healthcare delivery in the community, but also respiratory, diabetic, but beyond. And I think, Martin, that's what we interrogated in more detail when we had that meeting in Maynooth recently, and I think that was a fantastic gathering of all the different elements involved in digital health platforms, from healthcare delivery professionals right the way through to private enterprises who are working away and trying to develop strategies to try and improve healthcare delivery. And I think what was the amazing and memorable part of that meeting was to see the breadth and capacity of e-health transformation that could be with us as we try to improve healthcare delivery. And in particular, it was encouraging to see that these are no longer just ideas, that quite a few of them are marching into that zone of pilot projects, and indeed a few of them have gone beyond pilot projects and are now assigned a formal status within the health service executive healthcare delivery platforms. And just to mention a few, the virtual consultation service for delivering heart failure knowledge into the community, and this is an interesting way of delivering specialist care by moving the knowledge rather than moving the patient. And again, it's not just applicable to heart failure or to cardiovascular medicine, but to many other chronic diseases. And we saw at that meeting, Martin, as you remember, some other very excellent examples, such as heart care at the home, AI-assisted echocardiography, and then some very innovative strategies. Again, the one that Matt is leading up at Vincent's in a collaboration with some of our European colleagues with a heart failure avatar to help home care for patients with heart failure. So I think we now have everything aligned. We have, I think, the capacity to provide enormous developments in digital healthcare delivery, but we also have a foundation healthcare service that's looking at moving healthcare into the community, empowering the patients and trying to deliver chronic disease care in a very responsive way. And we're certainly looking forward, Mark, as you point out, as being a digital CV lab in St. Vincent's and St. Michael's. We're looking forward to elaborating on some of the projects that I've mentioned and some more of the great ideas that we heard about at the Maynooth meeting. Thanks, Mark.
That's brilliant, Ken. We're going to hear shortly from Dr. Matt Barrett, who will talk about the work around AI and Avatar, but also about the AliveCore device. So, Dr. O'Reilly, I don't know if you would be free now to come and talk to us. Let's check if we have our slides, but maybe, let's see, if you want to come up anyway, and we'll just check if we have them. We have on stick, so that's brilliant. So we will put them on my laptop here, please God. And next up we'll have Dr. Michael Suger, who's travelled from Letterkenny. So Michael, we'll just wait for to get the slides here. Just check if somebody has their laptop live. My laptop is unresponsive. Perhaps we'll give it to Connor there. Thank you all for staying with us. We still have some really interesting content, so as long as you can, please stay with us. So, Orla, thank you.
Thanks very much. Martin asked me to talk about the Enhanced Community Care Programme and digital. And I just want to give you a quick bit of background. The Enhanced Community Care Programme is basically a radical transformational reform programme to shift left for care and bring it to primary care and the community, and to stay left to keep it there. So we've been shifting and staying as opposed to staying and shifting, but I suppose we aren't in the same place. And also, we've had a bit of 10X, which is a new phrase for me as well, because we had quite a lot of pilot projects demonstrating the efficacy of this model all over the country for about 5 years. But suddenly we got a huge injection of funding, during COVID and from the capacity review. And now we're fully funded to shift to the community for the care of, well, the appropriate care, ambulatory care of cardiovascular disease, diabetes, COPD and asthma. So we're developing, there's 3 aspects to the Enhanced Community Care Programme. It's putting 96 community network teams in place to cover the country in 50,000 population patches. And then in 150,000 population patches, we're having specialist teams for chronic disease, for chronic diseases that I spoke of now, just those chronic diseases, not every chronic disease, and for older persons. So about 4,500 new staff currently being recruited, about 1,500 of those in the chronic disease area, which is my area. So this is our mantra, really. This is our model of care for chronic disease. And as you can see there, it starts at the bottom where it's keeping people well at home and moves up into general practice as the next level of care, then moves up to the specialist hubs, which are the 30 hubs we're talking about, which provide ambulatory care services, both community employed staff like specialist nurses, specialist physios, dietitians, podiatrists, and so forth. And then and outreach specialist teams from the hospital into those hubs providing OPD and that sort of thing in the hubs. And then, as you can see, the smallest element is actually inpatient care. So 90% of care for these conditions can now, or will now, be provided in the community. And we're actually implementing this right now. So we're actively recruiting all of these staff, and we're actively developing the capital sites for these hubs. Now, it's not all going to happen next week, of course, but we have about, of the 4,500 staff, there's almost half of them employed at this point. So it's X10 compared to what usually happened before this. So next slide, please. So this, I think, is the important sort of slide with regard to digital. Sorry, can you go back to the other one? I forgot a bit. The issue, I guess, in our model is this is what we're doing now, and this is an in-person service. However, it does provide the full spectrum of care, and it does provide the full response. But it's all provided face-to-face in the traditional model, which is needed, but it's not enough. We need to also go digital, not instead of, but as well as in-person care. We don't have enough healthcare workers now, and we certainly will not have in the future to care for all the people with chronic disease that need caring for, and need to exploit the technology that actually exists now to help us do this. So can I go on to the next slide, please? Yeah. So you could do a risk, predictive risk stratification from existing data if you had the system to do it, which we don't in this country. And you could predict the people who are going to be hospitalised with reasonable accuracy in the next year. And you would divide them into very high risk, about 1%, high risk, about 4%, rising risk, which are the very interesting people, about 35%, and low risk, which is about 60%. And the numbers I have under them are the people with chronic disease in Ireland that are about 1.3 million with the chronic disease I mentioned in Ireland, that fit into those categories. So as you can see, in the top two categories, not that many, it's not 60,000 or 65,000, it's not actually that many people. And in the rising risk category, about 450,000 people, which again is a manageable number, particularly if you're using e-technology. So we're putting in the face-to-face staff, and that's an expensive thing, as you can imagine, and we want to make the best use of it. So we should be putting in a population health management system as well as that to do the stratification I just spoke about. But just as importantly, because there's no point doing the stratification unless you're going to put in the targeted intervention. So the interventions then are case management, which we do face-to-face for the top numbers, but also the sort of care that people have been talking about today, like the remote monitoring, like the calling if something is going wrong, the ability to call into the centre and so on and so forth. Most importantly, the care gap analysis. This is something we don't do, but I know of companies here that can help us do that. We're going to start working with them. Is looking at, according to the guideline of how heart failure or whatever should be cared for, that we can see where the gaps are and then start addressing them at individual practitioner level and even at individual patient level. So then the rising risk group, this 450,000, they're a very interesting group because the literature would say this is where you get your bang for your buck. It's stopping those going up the pyramid to get to the people who are going to be admitted is where it really happens. And so you need to focus on them, but there's quite a lot of them. So you need to enable the professionals to do this with e-technology. So for instance, in the States, a lot of big companies in the States use outbound nurse virtual calling on this, and the caseload for a nurse doing that would be 200 patients. You know, compare that to what a caseload with CNS in the community would be here, which would be, certainly would be maybe 50. So, and they do a lot of things like health coaching. They will outbound call before your GP appointment, so you get the best out of your GP appointment. They'll call you after you come home to make sure you understand your medication, etc., etc. So it is enormously useful here. But I think the trick here is it needs to be integrated with the whole service we're putting in. So it can't be a standalone service to our call centre. That's the old-fashioned way of doing that. We never did it. This is the bit we should leapfrog. And we need to have it integrated with the community staff and the GPs and the consultants that we're putting in the in-person service. And then at the lower risk people, which are a lot of people, we need to be harnessing e-technology to target them specifically with what interests them in sort of, promotion of health and keeping well and so on and so forth. So if we know that they're overweight or whatever, the nurse targets them with a specific thing and gets feedback. And there are decision support systems that will help her do that on the case. So anyway, next slide, please. Yeah. So we haven't got that yet, but that's where we're going. Then, as of today, these are the sort of systems that we need, which we really haven't got. With the most basic clinical system, which messages GP and hospital systems. We haven't got that in the community. We're employing all these staff, we still haven't got the most basic clinical system. So this is the real life experience. Video conferencing and remote consultation. We've noticed some of the systems here. We've been talking to some of the suppliers that we've got to go through to plumb all the hubs for this sort of system. So that's a big jump forward for us. We have lots of programs which we're currently providing on a remote basis, even more since COVID, because we had to pivot to remote. But we're doing it in a higgledy-piggledy way, whereas we should be just providing, here's the system for the country, there you are, into the 30 homes, off you go. So at scale, basically. The quality assurance and analytical enablement, as I said, we're talking to the company about that because we want to identify those service gaps and address those. Population stratification and e-enablement, I mentioned that already. Self-management support, and a lot of the technologies shown here today are about self-management support. And ideally, what I would like to see is I'd like to see a kind of a standard adopted. So if you're a diabetes patient, in fact not just diabetes patient, if you're a patient with chronic disease, there would be one platform for self-management support. So it's not about 10 different things, and different one in Galway, different one in Kenny. That really